Welcome back to the Nurse Scrub Club. Shortness of breath, wheezing, and low oxygen. This can move fast. But here's the big question. Is this a COPD exacerbation, an asthma exacerbation, or both? The history and bedside clues help you tell the difference. The patient arrives with worsening chest tightness and wheezing. We start by asking about their history and recent triggers. Patient: I'm having trouble breathing. My chest is tightening up. Nurse: I'm going to check your breathing, oxygen level, lung sounds, and what may have triggered this. A COPD exacerbation means the patient's breathing suddenly becomes worse than their usual baseline. The airways are chronically damaged. Airways become inflamed and filled with mucus. Air becomes trapped, making it especially difficult to breathe out. An asthma exacerbation happens when sensitive airways suddenly tighten and become inflamed, often after exposure to a trigger. Bronchospasm, airway swelling, and mucus make it difficult for air to move. It's an acute, often reversible response. With COPD, look for breathing that is worse than their baseline, increased cough, and thicker sputum. Look for prolonged exhalation, fatigue, and low oxygen. A history of smoking or chronic symptoms is a major clue. With asthma, look for sudden chest tightness and rapid breathing, often linked to a specific trigger. Watch for accessory muscle use, difficulty speaking, and a history of allergens or exercise-induced symptoms. Here's the quick comparison. COPD is chronic damage and air trapping. Asthma is reversible tightening and inflammation. Both may wheeze, but the history of how it started tells the real story. Always look at the whole patient. Warning: do not assume louder wheezing means they're worse. In severe asthma, a silent chest is a medical emergency. In COPD, drowsiness or diminished breath, sounds may signal respiratory failure. Very little air movement is dangerous. Assess everything: rate, work of breathing, mental status, and the ability to speak in full sentences. Common COPD triggers include infection, smoke, air pollution, weather changes, and missed maintenance inhalers. Asthma triggers include pollen, dust, exercise, strong odors, and missed controller medications. Know what sets them off. With either condition, position them upright and apply oxygen as ordered. Monitor their response closely. RT: I'll start the nebulizer treatment. Nurse: Perfect. I'll watch the O2 sat and their ability to speak. Handoff: Patient has low O2 and accessory muscle use. Rescue inhaler provided no relief. We are starting treatment now. If they're tiring, we check an ABG. In COPD, watch for acidosis. In asthma, a rising CO2 means fatigue and impending failure. Family asks, is it COPD or asthma? Both cause wheezing, but COPD is chronic damage, while asthma is a trigger response. Teach the family the red flags: blue lips, confusion, extreme sleepiness, and a rescue inhaler that just isn't working. Recap: COPD is chronic damage and mucus. Asthma is trigger-related bronchospasm. History plus assessment is your best clue. Thanks for joining us at the Nurse Scrub Club. Don't forget to like, share, and subscribe. Bye for now.